Hello guys, I'm Raj Karthik, a second year MBBS student. Today we will be looking into the topic diabetic ketoacidosis. We will see why it happens, we will see what are the events taking place in it, we will see what are its effects on the functioning of the brain, and we'll also be looking into few of its management. So yes, this will be a gentle discussion more suitable for a first year MBBS student. So yes, let's get into the video. So diabetic ketoacidosis. To begin off with, what is diabetic ketoacidosis and why does it occur? Diabetic ketoacidosis is a metabolic acidosis which occurs in the body of mainly diabetic individuals where the body cannot utilize glucose for energy production, and it depends mostly on the breakdown of fat molecules to provide energy. When fat molecules are broken down, it gives off ketone bodies to provide energy. Ketone bodies are acidic in nature, so when their amount increases in blood, it causes an acidic condition to the blood. Diabetic ketoacidosis can occur in both type 1 and type 2 patients, that is, insulin dependent type as well as non insulin dependent type. But it is most common in the patients of type 1 diabetes as there is insulin deficient. It's because in type 2 diabetes there is insulin resistance, whereas in type 1 the insulin amount is deficient. Why is there an insulin deficiency in the body? In type 1 diabetes mellitus or insulin dependent diabetes mellitus, there occurs an autoimmune destruction of the beta cells of pancreas. These beta cells produces insulin. So when these are destructed, the amount of insulin produced reduces drastically. Whereas in type 2 diabetes mellitus or non-insulin dependent diabetes mellitus, there is insulin produced by the beta cells of pancreas, but the cells of the body show a resistance or respond poorly to the circulating insulin levels. We have now completed the first part, that is, we have seen why is there a resistance to insulin or deficiency of insulin in the body. Second, we look upon why is there a reduced uptake of glucose in the body, and further we will see why is the ATP reduced. Before we look upon why is the absorption of glucose reduced, we will look how is glucose absorbed into the cells. Just like any other nutrient, after digestion, glucose needs to be taken up by the cells for their energy utilization. Glucose cannot enter a cell just like that by diffusion. It requires particular transporters known as glucose transporters or GLUT. There are quite a few types. Among these, the insulin dependent one is only one type, that is GLUT4. The circulating insulin levels mediates the GLUT4 receptor and regulates the glucose uptake into fat and muscle cells. So this occurs in normal condition. But in diabetes mellitus, there is a deficiency of insulin, and thus the regulation of GLUT4 by the insulin molecule reduces in amount, and hence the glucose molecules from the bloodstream to the fat or muscle cell decreases, and hence the concentration of glucose in the bloodstream increases, leading to hyperglycemia. This is the main reason why there is hyperglycemia in diabetes patients. We have now seen the second topic also. We have seen why the glucose uptake by the cells is reduced. That's because the GLUT4 receptors are less active due to less amount of insulin present in the blood, and thus the glucose transferred from the blood to the cells is reduced, and there occurs increased blood glucose levels and causing hyperglycemia. Next, we will see the compensatory mechanisms which occur to provide energy in conditions where glucose is not utilized in the body. Since the glucose is not utilized by the cells for producing energy, the body depends on other nutrients for the production of energy, and these nutrients are fat and proteins. The amount of energy produced by fat is comparatively greater than the amount of energy produced by proteins. Initially, what happens is the glycogen, that is the storage form of glucose in liver, undergoes glycogenolysis to increase the blood glucose levels. Later, since this glucose is not utilized by the cells, adipose tissue or the fat tissue undergoes a process called lipolysis to form ketone bodies, which further produces ATP. Since ketone bodies are acidic, their increase in number in the blood decreases the pH and causes a condition called ketoacidosis. Later, the muscle too undergoes proteolysis, which is a breakdown of protein to amino acids, and these amino acids undergoes a process called gluconeogenesis to form glucose, which further increases the blood glucose levels. Even though these compensatory mechanisms lead to increased blood glucose level, the body cannot utilize the increased blood glucose as the GLUT4 transporters are not activated by insulin. Thus, the main source of energy depends on fat tissue. The fat tissue breaks down by lipolysis to produce ketone bodies, which further produces ATP, which is the currency of energy. Later, when ketone bodies are increased in the blood, it causes an acidic condition which leads to ketoacidosis. We have now completed the cycle as we have seen the compensatory methods to produce ATP, that is lipolysis as well as proteolysis. We have also seen that continuous lipolysis increases the ketone body formation, which leads to a condition called ketoacidosis. Next, we will look upon what happens to the functioning of the brain in diabetic ketoacidosis. To begin with, the uptake of glucose in brain is insulin independent, which means that the glucose transporter involved is not GLUT4. It is either GLUT1 or GLUT3. It is mostly GLUT1 supplemented by GLUT3. These glucose transporters transport glucose from the blood to the brain across the blood-brain barrier. Thus, even in diabetes mellitus condition where there is a deficiency of insulin, the brain can utilize the glucose present in the blood for energy production. We should also remember that in starvation and diabetes mellitus, the brain can also utilize the ketone bodies formed for energy production. But the satiety center of the brain alone is dependent on insulin for glucose uptake. That is, the transporter involved is GLUT4. The satiety center of the hypothalamus is the one which sends you signals to prevent you from excessive eating. Imagine you take a meal, you get a feel of fullness after a while. This feeling of fullness activates the satiety center, and this satiety center sends you signals to prevent you from excessive eating. This happens normally, but in insulin deficient conditions, the GLUT4 transporters do not work properly and the glucose uptake is reduced. Thus, the energy produced for the satiety center to work is depleted, and this center won't be able to send you the proper signals to prevent you from excessive eating. This is the main reason for polyphagia, that is excessive eating in diabetes mellitus patients. Next, we look upon metabolic acidosis. Metabolic acidosis is when the blood pH reduces due to the decrease in blood bicarbonate levels. Metabolic acidosis, in addition to diabetic ketoacidosis, it also occurs in starvation as well as in individuals who intake keto diet. They exhibit a particular pattern of breathing called the Kusumal's breathing, where there is rapid and shallow breathing. This is performed to remove the excessive acid formed in the body. Due to the ketone body acetone, the breath of these individuals smells fruity in nature. The blood pH drops less than 7.35, and the symptoms present are nausea, vomiting, thirst, drowsy, weight loss, and dehydration due to osmotic diuresis. To neutralize the acidity of the blood, the bicarbonate ions are utilized. Thus, when these bicarbonate ions are utilized, the bicarbonate level in the blood drops. Next, we look upon few of the managements. First, IV fluid. It is to treat the dehydration which has occurred due to osmotic diuresis. Next, insulin therapy. It is to activate the GLUT4 receptors so that the glucose is uptaken from the blood and hyperglycemia is prevented. Next, potassium replacement therapy. This will be slightly confusing, but we'll try to understand it. What happens in DK is that there is excessive hydrogen ions due to the acidosis in the blood. Some of these excessive hydrogen ions are exchanged with the potassium ions in the cell. When there is increased acidosis, there is increased exchange of hydrogen and potassium ions. And when the blood test is taken for these patients, it shows hyperkalemia due to increased potassium ions in the blood. But these potassium ions from the blood are lost through urine via osmotic diuresis. Later, on application of insulin, the glucose is utilized by the cells and lipolysis reduces and ketoacidosis decreases. Due to this, the hydrogen ions from the blood and potassium ions from the cell are less exchanged. Thus, the blood test later shows hypokalemia, which is less amount of potassium ions in the blood. Thus, to compensate the loss of potassium ions which has occurred through osmotic diuresis, diabetes ketoacidosis patients need to be treated with potassium replacement therapy, and the potassium levels should be monitored throughout the treatment of these patients. So yes, we have come to the end of the video. As we conclude this lecture on diabetic ketoacidosis, I hope you have gained valuable insights into this topic and you have understood the pathophysiology as well as its management. Remember, a thorough understanding of diabetes ketoacidosis is crucial for any medical professional. As I have already said, this is a general discussion and what we have learned is just a drop in the ocean. There's much more to learn. So yes, keep studying, stay focused. Thank you for joining me today and see you in the next video.